So thank you, Matthew, Santiago, and Rebecca for those great insights into your respective backyards, where you're really walking the talk on this issue, and the very nice illustration of both what seems to be positive and moving forward and helpful in some of the areas that need attention and collective thinking on how we can do better. So with that, I'm going to open the floor, and we look forward to people coming to, there's one central microphone, I don't know, and there's a wandering microphone. So if people want to just raise their hands or go up to the mic, you're welcome, and just introduce yourself and give us your comment or your question, and we'll take a bunch of those at this time. So the floor is open. I see Simon.
Thanks, Tim, hello? Yes. Yep. Tim, hi. Thanks very much, and thanks to all the panelists. My name's Simon Bland from UNAIDS in New York. Really understanding the urgency and importance around polio and the transitions you talked about, Tim. But I wanted to ask you one question, Tim, around many of us have had, a long-standing relationship and engagement with ministries of health. But when we talk about financial transitions, of course, ministries of health are often not that powerful. And so engaging more broadly with ministers of finance and with political legacies, heads of state and government, etc., are important. And the bank has a really important role in its financial relationships there. So thinking about your CPIA, I've heard Jim Kim talk a couple of times now about the importance of human capital spending as a pillar of economic growth, and actually using bank leverage more to think about that. So it's not just around taking concessional finance from the bank around infrastructure, but really thinking about and using your weight to promote more domestic investment in these sectors. Could you say a few words about that? Thanks.
Great. Others? Yeah. We have right here. Cool.
Thank you very much for a very good panel. I'm Ikuo Takiza from Japan International Corporation, CEO JICA. I have a question to Rebecca and also Matthew. To Rebecca, I really agree that we have to be prepared for the transition from to the eradication, and in particularly how we can really utilize the asset we build up together globally through the polio eradication program to the next program or the future programs. But if you compare the actual performance of, for example, the AFP surveillance with other disease surveillance, there's a huge difference. And one of the reasons, apparent reason, is funding, and how we can really, utilize this AFP surveillance, which is, developed and well funded, to other disease surveillance is really the question that we have to really think about seriously. There's no stable funding to transport the specimens, basically, other than the stool sample. So I think that is something that we have to really think seriously. And to Matthew, I think it is really a big challenge to convince the government to support like key populations or the CSOs, because as you said, it is the areas that which justified the global fund interventions, because there was limited or inadequate support to those areas. How are you successful in dealing with the government? I want to know some of the successful examples, if you have any. Thank you.
Good. We have Nduku here.
Yeah, so I have two questions for you, Matthew. And the first one is, how do you define, or is country ownership defined? And who defines country ownership? The second question has to do with financing flows. At the country level, ministries of finance and financing has a very clear sort of annual cycle, and that is similar across basically every country in the world. That there is a planning phase, there are approvals, there are negotiations, there's determination of envelopes, and so on and so forth. So as you talk about the transitions, how is that taken into account? Because none of the aspects you have talked about actually talk about the financing within the country.
Right, right behind, Carl.
The name is Karl Esselmeiden from Cored. I had a question. I think it was very interesting to hear 3 panelists and 3 institutions, and then including the World Bank, trying to transition and trying to get governments of low-income countries in particular to start taking over funding. And it happens not just in those 4, it happens elsewhere. Did anyone do an effort to try and summarize what proportion of budget you collectively are trying to transition to probably the 16 poorest countries over the next 5 years, and what that would actually do to the possibility to actually do that, or how would it skew ministries of finance to have to allocate money to health? Just that is because where the big collaborative multilateral money is, as opposed to, for example, education or science or agriculture, for example. So the question is, it sounds great, but if everybody does it at the same time in the countries that can do it, can afford it the least, it will terribly either be impossible or skew the national budgets based on international priorities rather than local.
All right, yes, please.
Thank you. I'm Naresh Goyal from India. Not a question, but just a comment on Rebecca's presentation. She mentioned India, and I was earlier the program head of the polio eradication program in India, so way back in 2007 to 2010. We are definitely utilizing all this workforce, all this capacity building that has happened over a period of time to go into other diseases and strengthening laboratories. And as you said, NCDs. Thanks for mentioning that. That's all I wanted to say.
Great, thank you. All right, John.
Tim, John Monahan, Georgetown University. It's a follow-on, I think, to the question before the last. I'm intrigued about how the different multilateral and also, I guess, bilateral, ultimately, programs are working together, not just in thinking through to avoid a problem in an individual country, but it would seem that there are aligned goals in terms of how you address the epidemics, and also how you think about financing, because it seems like you could be counterproductive to one another, in addition to potentially in terms of in addition to the impact you're trying to have in individual countries. So how do you coordinate?
Great. All right, Sir George.
Thanks very much. Very enjoyable presentation. I'd like to follow up on Carl's question. I just got today the HME's report on development assistance for health. And about these 25 countries that only have $86 a day, $86 a year for per person, how are you going to transition them? What are you going to do after development financing after this financing is over? They just don't have the money. You speak glibly about these countries transitioning and having money to sustain the program, but these countries don't. Some of these countries just don't have it. What is your answer to them?
Great. Well, I think we've got a good start. We get the easy questions in the first round. Matthew, why don't you kick us off? There were a few that were designated to you, and I assume you will deal with those. And then there were a few that I would call in the global public goods category, which means it's a non-exclusive, non-rival response that's required.
So, yeah, the easy ones, I guess, are in the first round. So I'll try to touch on a few of the themes that were mentioned. So on the country ownership side, there are people sitting in the room who know far more about the Global Fund than I do, but there's no way I'll try to define a very challenging term like country ownership. Because we all know that there are natural tensions between the way external financing interacts with domestic governments and country ownership. What I will say is that increasingly in our transition work, we need to be thinking about the ways in which we can positively incentivize countries to push to uptake these programs, integrate services into the health system, and make sure these gains are continued. And that's going to be particularly challenging. And I think that we have to recognize with transition that fundamentally it's a donor-driven and an organizationally driven thing, in the sense of organizations removing external financing. And so there are going to be some natural tensions with country ownership. I think that's the only thing we could say. What we need to do in our transition work is recognize those up front, particularly in the case of the Global Fund when it comes to key and vulnerable populations, and that's how I'll move. And we shouldn't be, to answer the gentleman's questions from Japan, we shouldn't just think that countries will naturally decide to fund services for key and vulnerable populations. So there's a number of things that we're doing that I think will help foster that. And I think there are some good examples. I recently came from a country in the Eastern European region that at the time of the Global Fund transition both committed and have started to spend significant more government money to provide prevention services to key and vulnerable populations. And so while it's going to be hard, there are good examples of it happening. I think one of the things that we can do to push it and to foster this is to think about the way in which our funding promotes and provides the correct incentives. So our co-financing policies can provide incentives. We can also think about how we increasingly push our funding through government systems so that when our funding decreases, government systems are actually those that are providing the services to key and vulnerable populations. Because if it's on budget and it's in the program, it's a heck of a lot easier to keep it than if it's in parallel. So there are some good examples of this. I think where you'll find the more challenging examples are outside of service provision. So for CSOs, there are some really challenging spaces around the important advocacy role that CSOs play. Governments are usually unlikely and reluctant to fund advocacy, yet we know that those advocacy organizations are essential to making sure that the human rights and other concerns of vulnerable populations are met in countries. And that's actually a space that I think we're just going to have to recognize that we're going to need other partners and other people to step in in order to help support. We can fund, and we increasingly do fund those things through our grants, both our multi-country grants as well as our regular grants, but we're going to have to recognize that that's going to be challenging. Let me hold there.
Great. Santiago, do you want to come in on a couple of those?
Perhaps tried a little bit the last three questions that were similar in terms of the feasibility of transitions and the collaboration and coordination and what are we doing. So actually when we look at the Gavi transitions, what we did was to look at, we estimated more or less what is the impact, the budgetary impact of our transitions, the funding that we were decreasing. Actually, when in our countries, it's around 2 to 3% of the government health expenditures. That's what we are talking about in terms of transition, the Gavi, the funding that is Gavi's phasing out. And this is without assuming any increase in health budgets, even though we know that some of these countries are only spending 3 to 5% of their budgets in health. This does not also take into account that what I was mentioning before, that some of these countries are spending two-thirds of their budgets on tertiary care, even though perhaps that's not the most efficient way of the resources, and that even in some of these countries, their revenues, there's a significant room for improvement in terms of tax collection and revenues generation. So even without looking at increasing that, just keeping the status quo, what Gavi is phasing out is around 2 to 3% of their general government budgets, which means it's a prioritization issue, not a fiscal issue. But perhaps one of the big lessons that we had is we were still looking at least in the early years, going individually, looking at immunization on our own, and trying to look at for some solutions. So we for a long time, we were looking and advocating for trust funds for immunization, our own earmark tax, instead of really looking at the system. And what now we have found out, and there are recent studies showing that there is no, actually, that looking at this silver bullet have not helped to increase additional resources to the sector in general, but all the opposite. So what we have done in the last years, this is what I mentioned, is that's why we are partnering now with the World Bank to look at, in terms of assessing the impacts of transitions, to look at the health financing assessments. So we are asking the bank to do a health financing assessment in all our countries that we are transitioning, even though we are 2 to 3%, but we need to understand the broader context and the perspective. Also because there are still some challenges like human resources, like public financial management, that will need to be taken care. And that's why we're collaborating with the bank. Also now we are starting also more and more collaborating with Global Fund, even though we're not transitioning with the Global Fund in countries at the same time. But we are working on sustainability at the same time. And those foundations, human resources, public financial management, increase of resources, are critical. So we are in that path. We have learned quite a lot. We're not there yet, but I think we have advanced significantly.
Rebecca. Yep.
Thank you. I'll start maybe with the question about the AFP surveillance and thinking about how is this going to be sustained, because it's real-time, high-quality surveillance with a mechanism for moving specimens. But I can tell you already that many other programs and countries have built on this and used it. So the value of it beyond just the polio eradication has been shown in many countries. I think this is one effort within the post-certification strategy that has to be maintained, the surveillance, not only acute flaccid paralysis, but we have been scaling up environmental surveillance as well in countries to be able to make sure we can truly detect and report if there's no poliovirus spreading. So the value in these and the importance of the continuing advocacy for resources to do this in the short term after eradication and after certification is critical. But then as they become more, let's say 5-10 years down the road, how this becomes more streamlined. So the value of making sure that it's valued by other programs, which it is, where those fundings are going to come from, and the importance of advocacy. We see Rotary Foundation, Bill and Melinda Gates Foundation talking about how we have to advocate for these funds. So this is a critical, important issue that it does have to be maintained after. Where are the funds going to come from? It's not just going to be left up to a country to decide, because we have to, this is a global eradication, and the importance of looking for the resources for that will be critical going forward. I wanted to come to the issue. One of the things we have worked with the 16 countries I mentioned is with the transition plans that they have all developed. Now, they all developed plans. They've got all their pieces together. They have advisory groups in country. They're using coordination mechanisms. But when it comes to having a costed, agreed-upon plan that's fully resourced, that's where we see the red color appear, and this dashboard is on the WHO website. But it just talks about the importance of the value of making sure that we have in-country agreement, but that there has to be that country buy-in to this with the Ministry of Finance and the importance of that work. And then just working together, I would say, with Gabi, there's been a lot of close collaboration. Gabi is part of the transition management group within the GPEI, and we also have worked closely with the Global Health Security Agenda and thinking about the efforts of where specific elements are put into place.
Great, thanks. So I'll just take a few of the residual questions. First on human capital. Thanks for raising this, Simon. It is very important, and perhaps one of the dimensions of successful transition is really building greater demand and recognition of the value of investing in human capital. Our analysis shows that if you look at what explains growth over time, that investments in education and health have a disproportionate explanatory power in understanding wealth and growth, and not only, but also inclusive growth. So these are things that the bank is mobilizing around and has developed something called the Human Capital Index, and that's really going to rank countries according to their performance in investing in health and education. And this is a strong view that we find too often, is that a lot of people think that health and education are luxury goods, consumption goods, and you do those things once you've achieved a certain level of wealth. In the early days of the bank, they used to refer to these sorts of expenditures in health and education as social overhead. It wasn't easy getting a focus on the real value of health and education within the bank, just like it is difficult getting a focus on it with ministers of finance. Simply getting the World Development Report, the title of the World Development Report in 1993, called Investing in Health. Larry Summers almost lost his job as chief economist because there was such an orthodoxy of economists in the bank who thought there is no such thing as an investment in health. So just to say that those who worked on the Commission on Macroeconomics for Health, Sir George wrote a wonderful chapter on investing in human capital, which is, I think, as true today as it was 15, 18 years ago. But this is very much where we're headed. So we see three types of capital, sort of physical capital, natural capital, the environment, and human. And we're very much expecting the bank's share of its total financing, concessional and non-concessional financing, to move towards a one-third than to where it's been. And so we've got some ground to make up. But our financing is very small relative to the total financing, and I think this is important. One thing historically, each of us are part of what I would call the billion-dollar adolescents or young adults. But had you said in 1997 that in 2018 you would have $6 billion global efforts around health, people would have thought you would deserve some form of DSM-4 diagnosis for delusion or some other psychiatric condition. And I think what happened when we moved into the billion-dollar era in global health financing, there was a little bit of an inebriation, in a sense that actually with billions you can do everything. And I think it's just recently, and the last 5 years, that people have realized that, no, we're talking $1 trillion health sector globally. And so the development resources, although we're much better equipped at $1 billion than $1 million, those three log orders, but the play in development finance is how this becomes catalytic and contributing to that domestic resource challenge. And that's, I think, the big change in behavior that we're seeing across the group. And it was really came together, I think, coalesced in the Financing for Development UN conference in Addis in 2015, where we have to become much better at understanding. And in health, we had some, and still do have, some problematic behaviors, whereby we're so bountiful that we create a culture of substitution, right? We give money to the health sector, Minister of Finance says, oh, thanks, I don't have to put my domestic resources there. I can take them and spend them elsewhere. So the Abuja targets, which all of Africa aligned around, less. It was 5 countries that had 15% of their domestic spending in health. In 2000, it was 4 countries in 2015, and there are different 4 countries. Right? So clearly, this issue of making sure that we get an additionality, right? That the development community is adding, but to a growing domestic picture is the challenge ahead of us. And I think we have to be humble. I come from a development finance institution, and we've been inebriated by big projects for a long time, to the point that our livers are giving out, right? But you need to really think, what is that transition? Because you should be asking the question, well, when can we actually have less grant financing? When can we do smaller projects? When can we really focus, as Larry Summers is saying, on global public goods as the lion's share of development finance? And if we can get there, that's success, only success insofar as we really have serious DRM, or not only DRM, domestic resource mobilization, but I'd say DRUM, domestic resource use and mobilization, because there's a lot of efficiency gains that we can get from better use. Let me finish by saying that there is growing work on projections of financing. And we did some of this around the World Health Report on financing UHC in 2010 with David Evans, my brother of sorts. And also Chris Murray's done some work on this, I think in this latest IHME report. And I think this sort of analysis is very good because it helps to stratify countries in terms of their domestic resource mobilization likely trajectories. And it's clear for a small minority, but significant, that we have a 40 to 50-year trajectory to get to a strong engine of national financing. And that's very important because we need to develop the expectations of the development community that that's reasonable. If we all think that somehow, as we did, and I'm sure everybody, I'm sure you don't know this, but I will tell you, that the reason we said 0.7% as the amount of development assistance to be contributed by development partners for development was based on a health for all type of vision that was articulated by Lester B. Pearson, a former Prime Minister of Canada, who was asked by Robert McNamara, the president of the World Bank in 1969, to lead a commission called Partners in Development. And that commission projected that the world would no longer need development assistance by the year 2000 if the developed world gave 1% of their gross national income to development for those 30 years, 1970 through to 1930, and to 2000. And that 30-year period, they projected, based on average growth, that countries would be self-sustaining by 2000 with this additional support from developed countries. And initially they said it was a 1%, and then they said, no, it'll be 0.7 because 0.3 will come from the private sector. Now, of course, we haven't met those objectives, right? But that geared expectations for a 30-year period. And I think what very important in your question, Sir George, is that we do need to think about how to orient expectations for different types of development assistance according to the likely trajectories of country needs. Because if we think somehow that a country that is very, very poor is going to transition in 10 years just because 2030 is the SDG target, we're going to mislead development assistance policy in such a way that we may find that we're going to lose ground for those countries that do need assistance. So I think that sort of academic discipline and analysis, it's always imprecise, but I think it helps structure the policy discourse so that we're working collectively into the future with more realistic horizons so that we're more likely to achieve successful transitions. Now, I've been given a very strong sign by Rachel that most people are in hypoglycemic coma, which means your blood sugars are low, and I think it's time for a coffee break. But thank you for the questions, and thank you to our panelists.